Hello everyone. I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will study a very important topic, that is pleural lesion. And you know what? A short note will come from this topic for sure. So let's study what is pleura. Pleura is a serous membrane covering your lungs. Like these are your beautiful boat-shaped structure lungs. You have a covering of pleura. Okay. So what are pleural lesions? Lesions are the abnormalities affecting the membrane causing effusion, thickening and inflammation. Okay. They can arise from inflammatory, infectious, autoimmune, neoplastic or the occupational causes. So we have seen what is pleura. You have also seen what is pleura in your anatomy lectures as well. Okay. If you are not very well versed with the anatomy of your lungs, I must suggest you should go and watch your anatomy lectures. Okay. Let's see what are the pleural lesions you have. First one is your pleural effusions. So see, you have something called as a pleural fluid. If the pleural fluid is, let's say, 10 ml, normally approximately it is normal. If it is more than 10 ml to 20 ml, then it is a case of pleural effusion. Then it is a case of pleural effusion. You have the types. The first one is the transudative effusion. In the transudative effusion, there is a low protein. There is a low protein and low LDH level What are the causes? The causes are, there is increased hydrostatic pressure. There is increased hydrostatic pressure, as a result of which what will happen? There will be congestive heart failure. Second thing, there will be decreased oncotic pressure. And we all know, if there is decrease in the oncotic pressure, there will be nephrotic syndrome, there will be liver failure, there will be liver cirrhosis that will take place, right? If there is high protein, that is more than or equal to 3 grams per dl, or a high LDH, they are basically caused by increased vascular permeability. The causes can be TB, the causes can be pneumonia and empyema. Now, you have something called as the pulmonary embolism. Okay, what happens in the pulmonary embolisms? You have the subtypes. That is, first one you have is the parapneumonic effusion. It is secondary to the bacterial pneumonia. Like, firstly, there will be the episodes of bacterial pneumonia that will take place, and further on this disease will develop. Second, you have this the tuberculous effusion. It is usually unilateral, and you have the lymphocyte predominant. Then you have exudates. What are exudates? In exudates, you will be having decreased protein, that is, the protein level will be low, and low LDH levels. What are the causes? The causes can be either you will be having congestive heart failure, that is the most common cause, either the cirrhosis, nephrotic syndrome, or hypoalbuminuria. Okay. The features are, it is clear, straw colored fluid, and usually bilateral. Then you have exudates. We have talked about exudates are, everything is increased protein and LDH level. The causes are tuberculosis, pneumonia, pulmonary embolism and malignancy. Features are, you will be able to see turbid and bloody fluid. See, I will draw the lungs. If these are your lungs, you will be able to see some accumulation of fluid. You will be able to appreciate some accumulation of fluid. Next, you have a diagnostic criteria called as a Leitz criteria. Okay, and it is very important. It will be asked in your exams. So make sure you are very thorough with this criteria, Leitz criteria. If exudates has one or more present, firstly, if the pleural fluid level is more than 0.5, and if the pleural fluid level and the serum LDH ratio is more than 0.6. So you have two numbers 0.5 and 0.6. 0.5 you have the pleural fluid. For protein it is 0.5 and for the serum LDH it is 0.6. So you have two criteria, that of protein and LDH, right? Next, let's talk about the conditions. The first one you have is the empyema. Empyema, PY is representing it is having pus. So there is pus in the pleural cavity. Like these are your beautiful lungs, right? This is, let's suppose, your pleural cavity. And here you are having pus. That is your empyema. What are the causes? The causes can be either there can be a complication of bacterial pneumonia, as we have already discussed. Either there can be lung abscess, and abscess means there is accumulation of pus. There can be any penetrating trauma, right? The features are there will be thick, purulent, foul smelling fluid which is rich in WBCs, because we all know that if by any chance we get pus, right, in our body, there will be increased level of WBCs that we will be able to see. What are the complications we can have? We can have fibrothorax, we can have bronchopleural fistula, okay. Next you have is the hemothorax. So hemo means heme. What does heme means? Hemoglobin. Hemoglobin is nothing but your blood. We have to draw our beautiful lungs again. These are your beautiful lungs. Now we will draw the pleura with yellow. This is your pleura. Here you will be having the accumulation of blood. Here there will be accumulation of blood. What are the causes? Why the accumulation of blood is taking place? So the causes of this is mainly due to trauma, mainly due to rupture of thoracic vessels, and mainly it is post-surgery. What are the features? There will be frank blood. What is frank blood? That means more than or equal to 50% of the hematocrit of peripheral blood. So we will read this in our hematology lectures as well. Next you have is the chylothorax. In the chylothorax, what happens? There is milky white fluid due to chyle formation. Like again beautiful lungs, again pleura, but now there is milky white, right? Let's just draw it like this. This is milky white. And what is this? This is your chylothorax. This is what your chylothorax. So it is mainly due to the thoracic duct injury, that is due to the trauma or due to the surgery or due to any obstruction if it is there. Then it is fluid is rich in the triglyceride. Fluid is rich in the triglycerides. Okay. So this thing you need to remember. Then you have is the pseudochylothorax. What happens in the pseudochylothorax? You have the cholesterol. You have the cholesterol effusion. You have the cholesterol effusion. And it is due to the long-standing effusions like the cases of tuberculosis and respiratory acidosis. Okay. Next you have is the pneumothorax. The first one is your spontaneous pneumothorax. What happens is there is rupture of small subpleural bleps. Okay. Like lungs, these are your pleura. Now somehow there is a rupture. There is a rupture that has taken place in your pneumothorax. So it mainly occurs in young people who are tall and thin males. Secondary is the underlying disease can also be there, like either the patient is COPD patient, tuberculosis, asthma, lung abscess, or the cystic fibrosis. The features will be there will be sudden chest pain, breathlessness, unilateral breath sound will be absent, and hyperresonance you will be able to see when you do the percussion. Okay. Next that you have is the traumatic pneumothorax. What is traumatic pneumothorax? Like these are your two beautiful lungs. Then we have to draw the pleura again. Somehow now injury or the trauma, like you were fighting with someone and that someone just took a knife and just stab you with the knife, right? So that is due to a trauma. It can be either iatrogenic, like while inserting the central venous line, right? Or while doing the pleural biopsy or the mechanical ventilation. Next that you have is the tension pneumothorax, and tension pneumothorax alone have the capacity to be asked as a short note. Okay, so you have to read this very carefully. So tension pneumothorax is a medical emergency. What happens is the air enters the pleural space during inspiration but cannot exit. Draw the lungs with me. Now we will draw only of one side. Pleura, right? Somehow there is traumatic injury that has occurred. So the air is entering the pleural space, but the air is not going out. The air is not going out. Why? Because maybe there are collapsed lungs. Maybe there is mediastinal shift, that is the compression of great vessels, which decreases the venous return and land up the person into shock. What are the signs? The signs can be there will be severe respiratory distress, tracheal deviation will be there, distended neck vein, and hypotension will be there. What is the treatment? We do this also is a MCQ alone itself. We do a immediate needle decompression in the second intercostal space. Next you have is the pleural fibrosis and plaque. So it is basically a fibrous thickening and scarring of the pleura. The causes are chronic pleuritis like TB and empyema, hemothorax, asbestos exposure. It is well circumscribed, dense, and highly in collagen. Plaques is there, the markers of asbestos exposures, but not pre-malignant. Okay, what are the pleural tumors you have? Obviously, if there will be accumulation of fluid, there are chances that tumors will also take place. So first one that you have is the solitary fibrous tumor. The origin is it is sub-mesothelial fibroblast. Okay, in gross you will be able to see pedunculated circumscribed. See, this is circumscribed like a round and round. Okay, in the clinical it is often asymptomatic but can cause hypoglycemia. Treatment is surgical excision. You have to give the surgical excision. Second you have is the malignant mesothelioma. It is highly aggressive. Tumor, and the risk factors is asbestos exposure will be there. In the pathology you will be able to appreciate in the gross the diffused thickening of the pleura will be there, and in the microscopy you will be able to appreciate the epithelioid structure and a biphasic pattern will be there. Clinically, the patient will present with dyspnea, chest pain, recurrent hemophagic effusions, and weight loss. Prognosis is very poor, and for treatment we usually go for the surgery. Next that we have to talk about is the secondary metastatic pleural tumor. It is more common than the primary tumors. The sources are lung, breast, ovary, stomach, and kidney. These are basically the sources. Then the presentations, you will be able to see hemorrhagic pleural effusions. The diagnosis is by cytology or by the biopsy. What are the clinical features you will be able to see? In the clinical features, you will be able to appreciate there is chest pain. And the chest pain is very sharp. Okay. Then there will be cough. There will be dyspnea, fever, malaise, and weight loss. And what are the signs you will be able to appreciate? There will be decreased breath sound, stony dullness, and there will be hyper resonance on doing the percussion. That represents that you are dealing with a case of pneumothorax. What are the investigations you will order? The first investigation that should come to your mind is chest X-ray. Right. Then you will order the USG. Okay. Then CT or MRI. Then the pleural fluid analysis. In the chest X-ray, you will be able to see the air fluid level. In the US, you will be able to detect the small effusions that are there. In the CT or MRI, you will be able to appreciate the thickening or the tumors. You will be able to diagnose them, right? And on the fluid, based on the fluid, either it is clear, turbid, bloody or milky, you will be able to appreciate the type of pneumothorax that you are dealing with, right? The types of pleural effusion that you are dealing with. What are the complications of pleural effusion you have? The first one is fibrosis, which leads to the restrictive lung disease. Then you have the empyema, that will lead to the chronic fibrothorax. Sepsis, that will lead to the bronchopleural fistula, and then you have the malignant spread. What is the management? Management is generally treat the underlying cause, whatever the cause is there, whatever the organisms that are there, you have to make sure that you treat them. For the pleural effusion, for the Transudate, you have to treat the systemic causes. For the Exudate, you have to do the therapeutic aspiration. For Empyema, you have to do the tube drainage and give the antibiotic. For the pneumothorax, if it is small, you have to do the observation and give the oxygen therapy. For the large or the tension pneumothorax, you have to do the what? You have to do the needle decompression at the second intercostal space. Then for the pleural tumors, if they are solitary, you have to do the surgical excisions, and for the mesothelioma, you have to give the chemotherapy. So this was all about the pleural lesions that we have read. Okay, just read this much for your university exams, because this question will be asked as a short note. Okay, so you have to read this topic in that manner. Anyway, if you are having any sort of doubt, please feel free to reach me. Feel free to DM me. Thank you so much.